Patty, thank you for staying around here today to talk to me about the second kind of piece of research that you're working on. Patty is currently doing her doctorate in nursing practice, and for those of you that are maybe kind of unfamiliar with this terminal degree, it is a terminal degree really for people that are practicing, is kind of the concept that you are still a practicing nurse. And so it's a little bit different from a actual PhD program in that we are not being asked as DNP students to actually go out and kind of do our own research, although that's sort of interesting. What we're really asked is a few steps above kind of what we're doing here in this research class, but really built on these foundational principles of finding a topic that's engaging, making sure that there is actually evidence out there in the form of research that we can kind of tap into, and then looking at that research and really thinking of how do we implement this, in what settings do we implement this, how can we use this knowledge that's already out there to benefit society in some way, shape, or form. And so you and I have been friends for a number of years. We've talked about a number of different topics that you've thought about approaching over that time, and talk to my research students a little bit on what it is that you kind of have finally settled on, maybe why that's important to you, and again, sort of similar to what we did before, how did you go about kind of finding that research? And again, this is a work in progress for Patty. She's not really through this, so it's a bit of hypothetical at this point of this is what she's found so far and how she's planning to implement it.
Yes. So I had done my master's work on bullying and lateral and vertical violence in healthcare, and really wanted to do my DNP project on that, and it wasn't working for the institutions that I could work with. So we tried a couple other topics, and those just weren't coming through in a way that met the needs of the facility and also met the requirements of the DNP project. So I have a friend who's a pediatric nurse practitioner, and she works in a mobile pediatric healthcare clinic that works on the west side of Chicago.
Okay.
And so they take their van and they drive it into neighborhoods and do school physicals, do immunizations, do follow-up things in high schools, do STD education.
Oh, wow.
They do, a lot of really widely varied things, so it's pretty cool. And this person has actually just completed her own DNP this past year, and so she worked on initiating a process of doing mental health screening with their high school students that they were working with. And the next step in that they wanted to implement is what's called ACEs screening. And the ACEs program stands for Adverse Childhood Experiences, and it's based on a research study in 1998 that was the first one to find a connection between adverse childhood experiences and adult health consequences.
Okay.
And what they found was that people who had one or more of these adverse childhood experiences were much more likely to have ischemic disease, diabetes, cancer, mental health issues, which isn't, that makes sense, but this was the first time that there had been real evidence that there was a huge difference in people who hadn't had those things and people who had. The alarming or surprising thing was that it was 90% of people had one, and there were an alarming number of people who had many of those. And these aren't just any bad experience. This is a family member incarcerated, mental illness or suicide in the family, poverty, homelessness, witnessing domestic abuse, any of these substance abuse in the family. So these are specific categories that the ACEs protocol came out of.
Does it include being a victim of abuse as well?
Yes.
Not only experiencing it from a domestic standpoint, but actually becoming a victim of abuse.
Yes,
okay.
Sexual, emotional, or physical abuse
are
all part of that as well. And now, since that seminal study in 1998, there have been thousands of studies by sociologists and social workers and medical people and nurses and all across the board confirming and showing. For instance, I have one study of people that are in juvenile detention.
Okay.
Almost all of those kids have had adverse childhood experiences. When you look at people who, if you name any category of children or adults, when they go back and look, there's a very large number of people who have experienced this. And what they've found is that having this prolonged amount of stress is called toxic stress, and it actually creates a constant inflammatory response in the child, which alters your DNA.
Okay.
So that is part of what they think is what predisposes people as adults to having much more significant health problems, because you've had this traumatic situation ongoing throughout childhood.
Kind of a chronic fight or flight situation that you're in, that your body's fighting against, and these toxins are building up, and just physiologically then we kind of adapt to being creatures under much more stress than the people that aren't having these experiences.
And that constant inflammatory response creates a greater likelihood of having all of these significant health care and limiting life, so significantly decreasing how long people are living. So we, of course, want children to be able to thrive and be in safe, healthy environments, but when you look at this from a public health situation, if we can find ways to support families and to build communities and to do these things when children are young, the outcomes of what will happen for our adult population, who then would become healthier, and we would have less chronic illness and less serious health problems or comorbidities, it has a huge societal possible impact if we really get on top of this.
So you're saying there is some hope with some early intervention.
Definitely.
That this is perhaps not completely reversible, but that we can kind of stop that inflammatory process and help them to go on to living healthier lives. Okay, wonderful.
And there is also some research that is starting to connect resilience and what creates resilience, because there can be some people who go through those situations and come out of it better than some kids. And what they're finding is that, of course, it makes sense that if you have reliable, trustworthy adults, then you are going to do better dealing with that. So if you've seen violence, someone murdered in your neighborhood, and you have a supportive community and your family is able to help you through that, you can do okay in that situation. So what can we do to build resilience in families? What can we do to build resilience in communities? Stepping out wider and wider to make to address the problem. And so there are lots and lots of things happening to address ACEs. There are coalitions. There's a lot of stuff happening that's coming out of California.
Okay.
There was something recently on 60 Minutes. There was a really good spot on that. There was something on the NewsHour, which is on PBS, and Oprah actually talked about it. So
well, if Oprah said it.
If Oprah said it. So it's becoming much more part of our understanding, and the recognition that if we do proactive things to help, you can really have a significant impact. The other example is that in Philadelphia, they got together the nonprofits and schools and healthcare providers to form a coalition addressing ACEs so that they could interweave all the work that they were doing together.
I love that.
Yeah, and it wasn't a seamless, foolproof thing.
Sure.
But they definitely found that having these groups all at the table saying, okay, how are we going to support children and families? How are we going to help families who are at risk? How are we going to bring all of our resources together to form the support that they need? What are you going to do in schools where children are hungry? That sort of thing.
Right.
So there are really wonderful initiatives that are happening, and the more that we are studying it, the more that we understand that it has a physiological impact. It's not just that this is hard on someone.
Right.
And there's also a generational impact, because then you find children that were abused as children grow up to be adults that are likely to abuse their children because they have been through these really difficult things. And we would say, well, you're an adult, you just have to do better. There is truth in that, but there is also a greater understanding that this is not something that's entirely in somebody's control, that there are physiological things going on, that there are societal, community things going on. And as healthcare providers, if we want to provide holistic care and help interrupt this cycle, we have to be mindful of how all these things are happening. So one of the things that you're hearing a lot now is trauma-informed education, trauma-informed care.
I was going to talk to you about that a little bit, because that's where that is the phrase that I am hearing in the school systems and in healthcare. So it sounds like you could take one approach of doing all of this research and trying to create here locally an Elkhart County kind of coalition of pulling these same people to the table and sharing your research with them. But again, you are going to partner with this friend that has the mobile health clinic and do mental health screenings.
So for us, my project is going to be implementing ACEs screening
At this particular clinic.
At this particular place. And so they have already implemented the mental health screening, so the next step of that would be to implement the ACEs screening. And then they're hoping to take that data and be able to go back and get funding to get social work and to get more support,
more resources
in
for
their clinic.
Oh, I
so
love that.
if they can show, which they have a pretty good indication that there's going to be significant ACEs among the population that they're working with, but they don't have data for it. So when they have that data, then they can go back and say, hey, we really need a social worker. We need ways to plug people into the community resources that are there. We need to have this structured in a more deliberate way to help address the things that are going on.
So one of the things that I would like to talk to you a little bit more about with this is, when you say this of gathering the data, we're clearly working with human subjects, and so one would be kind of what, if any, kind of IRB, internal review board kind of process have you had to go through, or perhaps you don't know yet, and that'll be something for the future. But again, anytime you're gathering information from human subjects that you need to kind of protect their information. So that would be one question. And then is there any concern kind of about the data that you would collect of people either not being trustworthy and upfront with the experiences that they have maybe personally led, or the environments that their children are in? Because it seems like some of the things that you're really saying as being these adverse childhood events, I would assume that maybe parents would not fully disclose that drugs and alcohol are being used around their child, or that their child's in an abusive environment. So how do you gather that data, I guess?
That is a big question. That's a question in the literature as well. So as far as IRB goes, this particular hospital does not have an IRB board, so the IRB will go through my institution.
Okay.
So if it's cleared there. My project, because we are implementing screening, is going to be largely about how to educate providers about how to do it, because there's this considerable amount of literature that says that either providers still haven't heard of the ACEs study, they know about the ACEs study and don't realize that it's something that they should be implementing, or it's uncomfortable to ask about some of these questions, and so people sometimes feel awkward about it. So my project is going to be mainly about how to educate providers so that they'll be able to do that. We will then implement the screening. But so as far as maintaining privacy, my project will be focused on the healthcare providers.
Sure. And they're already in a relationship with the patient where they need to honor HIPAA and those sort of things.
Exactly.
Okay.
And in this clinic, there is a consent form that is signed by the family members, since these are kids.
Sure.
That clears that. So we'll check through IRB how exactly that should be handled.
Okay.
But there won't be identifying information in the project that I'm doing that will point back to these kids.
So they're kind of
it'll be enough
protected. Yes.
Yeah, to
Great.
protect their HIPAA. Yes.
Anything else that we kind of haven't covered on this topic? It's such an interesting one, and I think we see this playing out in our schools of children that have been labeled with having behavior disorders and perhaps put on medication. Some of those are just really tied to them having these just really sad and traumatic events that have happened to them in their lives. And if schools and providers can be knowing that there's these screening tools out here, even if we can catch some of them and start intervening and trying to help these families, and like you said, the communities, be that the school systems or the healthcare providers with resources, what a great thing based on evidence. And I don't know if this makes you and I old, but when I think of it being from 1998, as you said, that doesn't seem that many years ago, and for it to be such profound work.
Right.
Right. But yes, again, I guess at this point is 20 years old, but how fantastic that And it does highlight kind of a problem within research that if we've known this for 20 years, it is a bit sad that people aren't aware of it, but that becomes kind of sort of the